As we regrettably watch the increasing numbers of incarceration for drug-related offenses, deaths by overdose, as well as the constant stigma, marginalization and criminalization of people who use drugs, we witness yet again the failure of the existing drug control system. Punitive and draconic drug control systematically leads to human rights violations and abuses, torture, discrimination targeting already marginalized communities, disproportionate drug sentences, arbitrary detention, ineffective compulsory treatment programs, and restricted access to controlled medicines, which leads to the failed access to the most basic health services. This failed approach rejects the fact that science and scientific evidence are relevant and essential pieces of the decision-making process. For these reasons, we find ourselves again gathering with renewed hopes that our discussions will highlight the relevant role of science on drug policy reform. The Global Commission on Drug Policy was created in 2011 by a group of personalities from the Americas and Europe, including former heads of state and government wishing to inspire better drug policy globally. Today, the Commission has 29 members who, aware of the failure of the current drug control regime, advocate for drug policies based on scientific evidence, human rights, public health, and security. At the international level, we as commissioners act as global ambassadors for the drug policy reform. At regional, national, and local levels, they tailor their actions to the context, capitalizing on their diverse geographic representation and knowledge. Our main goal is to achieve a profound reform of the drug control system in alignment with Sustainable Development Goals, SDGs. The Global Commission believes that drug policies must be based on scientific evidence and respectful of human rights, always putting people at the center. The Global Commission advocates for reform mainly by means of the following 5 pathways. 1, put people's health and safety first. 2, ensure access to essential medicines and pain control. 3, end the criminalization and incarceration of people who use drugs. 4, refocus enforcement responses to drug trafficking and organized crime. And 5, to regulate drug markets to put governments in control. This is important because there is a growing recognition that drug prohibition has failed to achieve its goals of a drug-free world while having a detrimental impact on societies. Over the past decade, there were impressive reforms around the world at national and sub-national levels. More and more countries are decriminalizing drug use, adopting innovative approaches based on public health, and legalizing formerly banned substances. In such initiative, policymaking informed by science has played an important role in upholding and strengthening a public health and human rights-based approach to drug policy. Therefore, the Global Commission recommends, inter alia, the promotion of national legal frameworks and practices in accordance with human rights norms. This involves putting people's health and safety, an approach that must overcome political barriers and be backed by adequate investment in evidence-based policy and practice. Program Director, allow us a moment to reflect on the role and relevance of science. According to the United Nations Office on Drugs and Crime, in 2021, around 275 million people have used drugs, up by 22% from 2010. By 2030, demographic factors project the number of people using drugs to rise by 11% around the world and as much as 40% in Africa alone. Punitive drug laws that impose disproportionate criminal sanctions is the main driver of imprisonment, having led to an estimated 2.2 million people worldwide in prison for drug offenses. Out of these 2.2 million people in prison for drug offenses, 22%, about 470,000 people, have been imprisoned for drug possession for personal use. Treating problematic or dependent drug use is a key responsibility of government. A wide range of treatment options exists, including various psychosocial, abstinence-based, behavioral, and substitution-based therapies, which have been shown to be effective at improving health and reducing social costs of drug misuse. Contrastingly, relapse rates for people released from compulsory drug detention centers are very high. For example, high relapse rates have been reported in Cambodia and China, with more than 90% of people who use heroin relapsing after release. This is one example of how science and science-informed policies should and could advance drug policy reform. The Global Commission reiterates that drug treatment should be a matter for health professionals working in the health sector. Coercing people into treatment through the threat of a criminal sanction is wholly unethical and counterproductive. Science can and should play a role to not only reinforce health and human rights globally, but also help communities achieve social justice. So a burning question that may be asked is, how do we move forward? Harsh measures grounded in repressive ideologies must be replaced by more humane and effective policies shaped by scientific evidence, public health principles, and human rights standards. Prioritization of science and evidence-based decisions in drug policy making is crucial to uphold drug policies aligned with human rights norms. This also includes to seek evidence-based and tailored prevention strategies and treatment for drug dependence in voluntary centers in community settings, while adopting an inclusive agenda for all relevant stakeholders to express their viewpoints while placing greater emphasis on the link between science and human rights dimensions of drug policies. As I conclude, the Commission is an independent high-level analysis and advocacy group working on drug issues in the Eastern and Southern African regions and aims at developing evidence-based policy recommendations for the political and civil society leaders on how to address drug trafficking, mobilize public awareness and political commitment around the issue, and promote local and regional capacities to address the multifaceted drug problem. I would also like to inform you that we are going to launch the Eastern and Southern Africa Commission on Drugs early next year, which I will be chairing along with my colleagues, former head of states and high-level experts from the region. The Commission is an independent high-level analysis and advocacy group working on drug issues in the Eastern and Southern African regions and aims at developing evidence-based policy recommendations for political and civil society leaders on how to address drug trafficking, to mobilize public awareness and political commitment around the issue, and promote local and regional capacities to address the multifaceted drug problem. As I conclude, I must ask the question, can true prosperity ever be achieved if our most vulnerable are left behind? We are all a composite of humanity, and therefore every person is crucial in the project to create a sustainable, equitable, and inclusive society. To understand citizens who have been sidelined by society and who are suffering is to show that we care for them. To care for our fellow people is to do our best to offer them every chance for them to heal, to be seen, and to be heard. Let us give a voice to the marginalized and make sure that vulnerable communities are afforded the rights given to every person in South Africa, across Africa, and the world. And I thank you for your kind attention.
So that was a strong address by President Motlanthe. I'm realizing that I welcomed everyone in the room, but I didn't welcome colleagues who are online. And thank you. We have someone here in the room who will be taking questions that may come online and that I hope we have time to discuss at the end of the presentations. So the scientific evidence is clear. The war on drugs, repressive, punitive law enforcement has failed to deal with the issue. We need to change paradigm, and yet the world sticks to these policies. And that's why the Global Commission, the forthcoming Regional Commission will be working on what President Motlanthe was discussing, health and human rights-based policies instead of repressive prohibition law enforcement. So we'll open this with a discussion with 4 brilliant panelists. The discussion will be global, but with a strong focus on Africa, using the opportunity of the World Science Forum being in Cape Town, South Africa this year. And let me call right away on Professor Monique Marx, who is a research professor at the Durban University of Technology, a co-director at the Belhaven Harm Reduction Center in Durban, and a co-convener of South Africa's first scientific demonstration of the efficacy of what was called opioid substitutive therapy, is now called agonist maintenance therapy. So, Monique. I'll ask speakers to try and stick to 7-8 minutes so that we then have time for discussion.
Thank you very much. Okay, thanks. Okay, let's see if I get this right. Hi, everybody. Oh, it's up already. I'm not going to go into all the stuff that's already been spoken about. I'm trying to. Why is it not moving? Am I doing it the wrong way? Yeah. So we all know already the evidence around the problems with a sort of punitive, abstinence-based approach to dealing with drug use disorders. I just wanted to reiterate what the President was saying earlier on around the lack of efficacy of abstinence-based programs. And I think in South Africa, what's very clear is even if you go on a terrible outcome, which would be abstinence, most centers, which are called rehabilitation centers, have at most a 7% success rate according to the abstinence-based outcomes, which is not necessarily one which we necessarily in the harm reduction field would think is a good measure of a good program. Instead, what we tend to focus on is on positive changes in quality of life. And I'm going to speak a little bit about that and how really what I'm trying to say is that even despite the evidence, there's very little take-up of science, if you want to call it that, around dealing with drug use, both at the local, national, and broader levels. I'm going to stick very much to a South African example, if that's okay with everybody. But I do want to say, before I move on, you know, science is a very strange thing. And I'm saying this to the chair. Science has taken us into very bad places as well as very good places. And I think that we need to be cautious about thinking that all science is necessarily good science and that all science is necessarily objective. As a social scientist, I'm very cautious about that. But I think that there are some indicators that we really should be led by. And so the title of my talk was really about why people tend to ignore science. And I'm reminded from the previous panel of something that Michelle said, which was that, you know, evidence is often taken up in ways that are very politicized. And we need to be very aware of how political the decisions that are made around science are. I thought what I would do is I would mention some of the outcomes of various what could be called scientific, objective survey results that have been done at the Harm Reduction Center, which I co-direct together, actually, by the way, with Sean Shelley, who's at the end of the panel there, because I think that they are very, very clear indicators that should be responded to in a way that says, let's at least take serious consideration of this. So the Belhaven Harm Reduction Center has been running since the beginning of lockdown, COVID lockdown, and continues to run. Its main focus, I'm going to use the old term, sorry, Michelle, because it's in the PowerPoint, is to provide opiate substitute medications, albeit at a suboptimal dose, to between 160 and 200 homeless and low-income people on a daily basis. And we're situated in a central area in Durban. What we have come out with from our quality of life and our attention studies are the following, and I think they're really, really important to look at. And the first one is an 80% reduction in arrest rates, a 75% increase in retention on other chronic medications. So, for example, medications for TB, for HIV, for hepatitis, and for a range of other medications which we do provide at the Harm Reduction Centre. An improvement in general well-being and self-care, and of course a dramatic reduction in drug use, according to what the self-determined goals are of our individual clients. And then I think very importantly, an increase in help-seeking behavior, which really is one of the top outcomes of the move towards decriminalization. I thought I would bring up this table because I think it's pretty interesting to look at what was the substance use pre-accessing treatment in the Harm Reduction Centre and post-access. And what you'll see is very significant declines, particularly in the use of some of the drugs which many would consider to be more harmful, and less consumption of drugs which perhaps are less harmful, although even that is up for debate and discussion. But I think that given the sort of worldview around various types of drugs, I think this is evidence that is very, very important. And so you'll see the decrease, for example, in the use of opiates, particularly heroin, and an increase in the use of cannabis. Now, some people may say that that's a problem, but for us, that really is an indication of good harm reduction. And we actually promote the use of cannabis as a way for people to deal, for example, with some mood disorders, but also with, with problems that people may have with sleeping. What we're trying to get away from is the various judgments around the choices that people make. But this should be substantive evidence on its own in relation to a program such as this one. For me, this is obviously a very subjective outcome, but it is really important. We all want to feel that we are both happier and feel a sense of well-being in our everyday lives. And it is important to note that our clients say that they feel so much healthier having been on this program than they did previously. So going from between 0 and 10% to almost 90% of our clients saying that they feel a lot healthier. And that is because they are able to get on with their daily lives, they are able to take care of themselves, they are able to feel that they are able to operate with clarity of mind. And another one that I think is incredibly, incredibly significant is the arrest rates pre and post initiation onto the methadone program. So prior to coming to Belhaven, the arrest rates between 1 and 5 was about 70%, and you'll see that that has reduced to even less than 10%. Now, again, this is a very, very important marker. So what does this mean at the national government level? How have they taken not just the evidence from Belhaven, but the evidence from similar projects that operate throughout the country, in Pretoria, in Cape Town, in Johannesburg, in Port Elizabeth? Well, we still don't have any guidelines that have been given to us on opiate substitution therapy. We still do not have opiate substitution medications on our essential drug list. There is no ring fencing or resources for government support for harm reduction programs. Our policy frameworks conflict with one another, so the Department of Social Development does not align itself, for example, with the Ministry of Police. There is a huge reliance on non-government organizations for rolling out all harm reduction programs, despite having harm reduction in our national drug policy frameworks. And the proposed pilots for testing out the rollout of, for example, opiate substitution therapy by government are not going to be done in community-based settings, even though those are where they currently exist and require support. In terms of local government, there are also huge deficits. So Belhaven is run in a space which is owned by the municipality, and yet we cannot procure medication through local government because it is too complicated and because the pharmacies are provincially based. There is no budget within municipalities for harm reduction or actually for homelessness, which is something which is growing, not just in South Africa, but worldwide. Local government and national government remain highly politicized in the way in which they deal with the executive decisions that they make. There is no other explanation for why there would be no take-up of the evidence if it wasn't for fears of political repercussions for moving towards a more harm reduction frame. Democratic participation is at its weakest, I think, in South Africa since the beginning of the democratic regime, and so there is no engagement with people that are homeless or people that are marginalized, let alone people that are in the field of science. Our local governments fear experimentation, and so they stick with what is known, and they do not engage, as far as we can see, as scientists and as advocates and as activists in the world of science and evidence. And instead, they do what has always seemed to them to work, even though what we see is a growing number of people who are embedded in active drug use, which is problematic, rather than drug use, which is not problematic. And I think we need to really understand why that's happening. And that is happening in the face of what I call the burden of the future, looking into a future which is very, very bleak. I want to end by talking about the misalignment also of donor funding in relation to programs such as ours. I think there is an overstated correlation with interventions and donor funding in relation to HIV, and now a little bit in relation to hepatitis. We need to be having new scientific evidence that delinks these from one another and recognizes that drug use disorders have a right to exist in their own domain in relation to funding. There's too much of a focus on injecting drug use, which is completely out of sync with the modality of drug use in many of the cities in South Africa and across the African continent, which is often smoking or chasing rather than injecting. There is also, strangely still, and I recall this from recent conversations with people from even the Global Fund, who do not believe that providing agonist therapy to people that are not injecting is useful. There's a lack of recognition that, in fact, if you intervene when people are still smoking or chasing, you're actually preventing an onward transmission to injecting. And the failure to recognize this means that we are in situations where we are constantly trying to chase donors to recognize what is happening at the localized level. And then, of course, within the South African context, and I'm not sure how it works in other African countries, and I'm happy to hear about that, is that we do have what I'm calling monopoly NGOs who actually govern all the funding through what's called sub-recipient funding. And the problem is that if you are not a recognized entity in relation to a monopoly NGO, then you will not get the donor funding that comes into the country through really some form of bilateral agreements. And so really, the evidence should be taking us to a very different place, to looking at what works in grounded practice, to removing barriers to accessing harm reduction services, to aligning policy at all levels of government and between government departments, to investing in community-based interventions both in terms of government at all different levels and also the donor community, and to having a much more undifferentiated approach to all people who use drugs. Thank you very much.
Thank you very much. That was a brilliant talk, and I fully agree with what you said about sort of it's time to take out this field from the field of HIV and build it as an independent field. Also very interesting list of issues that you put in the South African context, but we later will hear from Adeolu, because I'm sure similar issues are seen in Western and Southern and Central Africa. So Adeolu, this is now time for you. Adeolu has been a key person in the West African Commission on Drugs, West African and Central African Commission on Drugs, that was launched in 2014 by Kofi Annan, former Secretary General of the United Nations, and one of the founding members of the Global Commission on Drug Policy. And Adeolu comes from Nigeria, but he'll speak about more generally the region and the work of that commission. It's a pleasure to have you here. Thank you. Okay, excellent. So then the next speaker will be Sean Shelley, who is a policy and advocacy human rights manager at TB HIV Care here in Cape Town, and who is the founder of the South African Drug Policy Week, which is an important event bringing here, 200 people or so every year for a week of work and debate around drug policy and reforms. Sean.
Thank you very much. So today I'm talking about why the voice of the community, and in particular people who use drugs, actually matters. There's a saying in Burundi, whatever you do for me, but without me, you do against me. And I think this is a principle we must remember when we are designing policies and interventions for people who use drugs, and indeed for other marginalized communities. So why include people who use drugs? Should we do it because it's a principle? Because they can reach hidden populations and help us reach our targets? I would say that there are better reasons. They hold institutional knowledge amongst the people themselves in their organizations. They have an understanding, insight, and a credibility, not only with their community, but with other communities as well. These are two photographs from the AIDS conference in 2016. And I heard a couple of people say the same thing, which is if you want to hear the problems, go to the main sessions. If you want to hear the solutions, go to the community village. And I think that's true to a large degree. And in fact, the first picture that I pulled up there from 2016 has only got problems listed on the slide in the background. And there's a group of people at the networking zone where Professor Marks was as well, actually, helping organize that, having discussions and coming to some useful solutions. Oops, sorry. Okay, so every year I do an exercise with people at the opioid unit at Stickland Hospital, where they are there usually for detoxification or for initiation on treatment. And the exercise is, and excuse the terminology initially, I ask them, I say, describe an addict purposefully. I'll use those words. And then I come up with these words. They come up with these words, should I say, dishonest, unreliable, liar, hopeless, criminal, sick people, all right? Ask the same group of people who use drugs, sorry, in denial is another one. What does it take to maintain a drug dependence? And we come up with a very different set of words. Focus, planning, commitment, resourcefulness, survival, being persuasive, and being thick-skinned. And when I do this exercise, you can see the change in people's attitude and how they stop perceiving themselves as somebody who's in denial, dishonest, sick. They realize that they've got a set of skills, and these skills, when focused on the right things, can be tremendously useful to them and to the communities in which they live. So I'm going to talk just very briefly about 2 reasons, plus one more, sort of an overarching reason, why we should include people who use drugs. They have a collective knowledge that others don't have, and they have insights and narratives that can inform effective drug policy. These are the 2 things I'm looking at. So the first thing I'm going to touch on is a fault of science, and people who use drugs can actually hold science accountable. And this is that the myth of Niobe, Wunga, Unga. Now, if you go to most people, you ask them, what is Niobe, Wunga, Unga, and they'll tell you, oh, it's ARVs mixed with cannabis, sometimes mixed with a bit of heroin. It's just not true. This is a recent paper, Recreational Use of HIV Medication, Antiretroviral Medication and Implications for HIV Pre-Exposure Prophylaxis and Treatment. Okay? These are the questions that they asked people when determining whether or not they were using antiretroviral medication for recreational use. Have you or someone you know ever used ARVs to get high, or another mixture of substances that you suspect may contain ARVs to get high? This mix sometimes called Niobe or Wunga. Now, how that gets past peer review, I have absolutely no idea. Because this question was asked of 14 to 16-year-old adolescents. Now, most 14 to 16-year-old adolescents in the settings I've worked, and I've worked in a lot of settings, would have no clue what you meant by the recreational use of ARVs, but they've all heard of Niobe or Wunga or Unga. If you spent any time in the poor areas of Tanzania, where drug use is fairly common, they will tell you what Unga is. It's heroin. They go on to say, in the second question, how have you or someone you know used ARVs or mixtures of substances that you suspect may have contained ARVs to get high? And this goes back to the first question again. So we have no scientific basis for ARVs being part of Unga and Unga. We are about to have that because some of us actually thought, well, this is something very easy to test, and have gone and tested it. It's not published yet, but it will come out, and I can categorically tell you there are no ARVs in Niobe, Wunga, or Unga. And this has got huge consequences. This is a systematic review of risk factors and consequences of Niobe usage. And they say that South Africa currently has the highest number of people on HIV and has got an extensive availability of ARVs. But in the light of recreational use, we must be careful of not having extensive availability of ARVs. That is an incredibly dangerous statement. They then go on to say, psychiatric effects, efavirenz is one of the primary drugs used in ART, and it's found to have psychoactive effects similar to LSD. They obviously, clearly did not consult a person who uses drugs. Because I know people who've tried to get high on efavirenz and who've taken LSD, and they are very different experiences. There might be some similarities, but they are not anywhere close to the same experiment. And if you go out into the streets of Cape Town and you go and ask somebody, please can I have some heroin, and then go and a packet of Niobe as well, they will laugh at you. It's the same thing. It comes from the same root to the same people. If you had have bothered to ask people who use drugs, what is this thing called Niobe, they will tell you what it is. Of course, the big risk is you can get a self-fulfilling prophecy as well. So the initial research that named this relied on anecdotal evidence from people who do not use drugs. And from then on, this thing has run. So people who use drugs should be included in the design of scientific research and study on people who use drugs and drugs of use. Here's my second point, is how to use consultations with people who use drugs to develop effective policies. A few years ago, ahead of the development of the new National Drug Master Plan, the previous National Drug Master Plan, as many of you will know, didn't have a very accurate description of harm reduction. It considered treatment to be harm reduction, abstinence-based treatment. So what we did was we took, with very kind financial assistance from UNODC, we took the executive members of the Central Drug Authority in small groups of 3 to 4, and we put them in the same room as about 20 homeless, street-dwelling people who use drugs. And they were given 15 minutes to talk to the people who use drugs, and the people who use drugs were given the rest of the day to talk to them. They weren't allowed to do anything except ask questions. They weren't allowed to lecture. They weren't allowed to present. And what we did was we asked several questions, which I'm just going to run through very quickly. I started using drugs when, I kept using, I keep on using, the things that have helped me, the things that have made my life more risky, frequent, or worse, and the things that would help me the most. And we got a whole lot of answers around that. You can ask for the presentation afterwards. I'll give it to you if you want to have a look at these. I'm not going to go through them now. But we got very clear themes coming through. And what happened was, if we go back to here, is we got a new National Drug Master Plan with 5 principles in it, which are incredibly valuable. What happened was the people who were there from the CDA, although they'd been working in the drug field for many years, had no idea what the lives of people who use drugs were like. And as a result, they included things like, it is now mandated to include people who use drugs in local drug action committees, in the discussions around the things that affect them. It is now mandated that there's an intersectionality, and there's space for the debate around decriminalization in the new National Drug Master Plan as well, which would be human rights-based, evidence-based, inclusive, multi-sectoral, and considers the voice of people who use drugs and based on human rights. Okay. So, at the end of the day, what did this do? Why did the Central Drug Authority change? It's for one very simple reason. Because as they sat there in front of these people who use drugs, what happened, there was a transformation. Ultimately, they just became people. And that's what we're looking at. You need to include people who use drugs in policy making, in your work, simply because they are people and their opinion is as valid as anybody else's. They hold institutional or specialized knowledge based on the institution of the drug user, which is often framed by stigma. Remember, we are dealing with people. Thank you very much.
Thank you very much, Sean. So let's now turn to you, Adeolu, and again, Adeolu will speak on behalf of the West African and Central African Commission on Drugs.
Thank you very much, and thank you, everyone. It's actually a great pleasure to be in our midst to make this presentation this morning. So this is actually titled From Resistance to Implementation, Lessons from Needle and Syringe Pilot Program in Nigeria. And this is basically is going to just take us through some lessons and also look at the context of drug policy in West Africa, which is actually applicable to the global context as well. So I guess this is, oh, okay, sorry. Okay, just a quick introduction of the West African Commission on Drugs. And this was actually convened in 2013 by the former and late Kofi Annan, the UN Secretary General, and is currently being chaired by the former president of Nigeria, President Olusegun Obasanjo, and the co-chair, Dr. Michel Sidibe, who was also the former director at UNAIDS and Minister of Health in Mali. And the West African Commission on Drugs was convened with 3 basic objectives, and is so soothing, and I'm happy to hear about the Southern and Eastern Commission, which is going to be launched in February, and basically to develop evidence-based policy recommendations to mobilize public awareness and political commitment, develop local and regional capacities and ownership. This was actually set up at a time when drug policy discussion was an exclusive right within just law enforcement, and at a time where you don't get to see civil society participation in the conversation, and issues around drugs are actually not on the front burner, not even seen as a public health issue. So it was actually a bold move, it was a bold step, and an issue that was of importance for the region to begin to talk about an issue in the open that actually affect almost everyone at the policy, community, and also within the household level. In 2014, the flagship report of the Commission was launched, which was the Not Just in Transit, Drugs, the State and Society in West Africa. This report actually reflected what the current thinking around drugs in West and Central Africa has always been. We always hear about it's just a transit region. Drugs are only just passing through. Why should we be bothered? And because of the perception that drugs are only just passing through the region, policies and laws are all, were also developed to respond to the transitory nature, what was believed in terms of drugs just passing through the region, and not really look at the fact that we are having a region where drugs are also being produced and substances are also being consumed in large nature, so that we can develop a policy that can adequately respond to this issue. In 2018, a similar groundbreaking report was also launched, which happened to be the Model Drug Law for West Africa, a tool for policymakers. This took a bolder step forward to say, look, having done a lot of consultation within the region and meeting with policymakers, we were usually asked the question, what should our law look like? What should be a model drug law that you want to recommend? And we came up with this tool. Interestingly, a critical component of both Not Just in Transit recommendation in Not Just in Transit and the model drug law was a need for harm reduction policy and implementation within the region, because the reality of the data available shows that drugs are not just passing through, they are also being injected, and the effect is actually profound. It's interesting to learn about what is going on in South Africa, where we, despite all the challenges around the harm reduction programs, but we can still see an advancement in the implementation of harm reduction program in South Africa. But this wasn't the case in West Africa and Central Africa, where everything just resides within law enforcement process. So the Commission had an Herculean task of promoting the idea around the public health response to drug use. But I wanted to just do a quick reminder, because this is to set a context on the situation, later narrow down on the case of Nigeria, and understand the context, for those of us who are not in the field of harm reduction. A quick reminder about why harm reduction is actually important. Harm reduction is about the science, it's evidence-based. A lot of evaluation studies have been done, and it has proven to help reduce HIV, hepatitis, TB, overdose burden among people who use drug. This is actually established. A lot of studies have established this. So this is something that is in sync with what the public health response should be. 2, harm reduction provides an integrated approach, taking account structural determinants of health to reduce vulnerability. Like Sean was mentioning in his presentation, we talk about homelessness, people who use drug, people who, who are on the street. The major thing they think about is about survivor. So there are actually issues that improves or increases the vulnerability of individuals to drug use and to death, even when you talk about overdose cases. So harm reduction is able to bring into together an integrated approach where we are not just looking at provision of medication, we are not just looking at information dissemination, but we are also looking at the structural determinants of health, issues that affect the individual or that increases their vulnerability. Then another quick point why the harm reduction is very important is that a drug-free world is utopia. We always hear about a drug-free world, we can do it, we have, drug control master plans being developed talk, with a focus on the drug-free society, the truth of the matter is that we cannot have a drug-free world, but we can reduce harms related to drug use. And this is also where harm reduction also comes in. Then harm reduction is pragmatic. It's just a sensible thing to do because it bridges the gap between the transition. Oftentimes, the goal of most drug policy is around abstinence. Harm reduction does not have a goal of abstinence, but even if the goal of the individual is abstinence, harm reduction provides the safe space between the transition from drug use to no drug use, in the sense that you are able to help an individual to be well, to be free of diseases, to be free of any form of casualty, even when they choose, to abstain. So even when that is not the goal, it provides a sensible approach that can actually stand in between drug use and no drug use. Then the last point here is that it provides a commitment to public health and human rights. It's able to connect marginalized people to social services. This is very important. It's part of the pragmatism of harm reduction. So if we have this at the back of our mind, we see that this is actually an approach that is required in any society where there is drug use. So it's not just something to think we just talk about supply reduction and demand reduction, but harm reduction is also very central. Again, a quick reminder why needle and syringe program. There is a whole consolidated program component for harm reduction, and one of the key services to be provided is needle and syringe program. A report released by the Harm Reduction International, recently showed that needle and syringe program is being implemented in 92 countries globally. And when you look at Africa, we have about 20 countries, which is an improvement from the previous year, who are now implementing needle and syringe program. And needle and syringe program is just a simple program where you make available to those who inject drugs clean needles in order to avoid the use of contaminated needles, because those who inject drugs are at a higher risk of transmitting HIV, hepatitis, and other communicable diseases via use of contaminated, syringes. So you can see a typical graph, showing a context where harm reduction needle and syringe was introduced, and the HIV rate, how it declined, in the case of Ukraine, and in Philippines, where needle and syringe program was not introduced, and you can see how the HIV rate among people who inject drugs actually increased over the years. So we know the science, we know this has been evaluated, and it has proven to work. But this has really been implemented. Why? For decades, the evidence has been there, but why is it that it's just not up until recently, a country like Nigeria, who has had heavy burden of HIV, is just implementing needle and syringe program as a pilot. Interestingly, this year, a scale-up has actually started, but why the delay? And this is also applicable to many African countries because there are lessons that we can learn. First, looking at the country context, the first integrated biobehavioral surveillance survey that showed HIV prevalence among people who inject drug and needle sharing was conducted in 2007. However, the first nationally approved NSP pilot was only implemented 13 years later, with 4 sites, 3 supported by the Global Fund and 1 site by Youth Rights Nigeria, with a pilot program. By 2014, the country, through its mode of transmission model, was able to prove that 9% of annual new HIV infection is being contributed by people who inject drugs. So the evidence was there, but the implementation of this simple program was not implemented. A number of inhibitors, and I'm just going to highlight a few: the criminal justice system versus the public health response. As long as drug use and control is still within the principal domain of law enforcement, it will be difficult for a effective public health response, because when the law, favors or gives the entire, control to law enforcement, public health, suffers. This was one of the, cases that, that Nigeria experienced. Then the issue around misinformation and public perception. We need to take on the reality that public perception actually drives, drug policy in a number of ways. So when the public perception is around abstinence, nobody, or oftentimes the stakeholders and policymakers really want to listen to argument around having a middle way, or people being free from infection, or people being stable or not going into dependence as an harm reduction practice. So the public perception is all about abstinence. So when you are talking about needle and syringe program, it's all about we need to take people to rehabilitation. This shouldn't be an option. Then a lot of moralization. We hear around issue around why should you give clean needles to people who inject drugs when they should stop using drugs? And we had to let them know to say, look, what is immoral is you allowing an individual to contract HIV when that could actually be stopped by a needle and syringe that is less than $1. So moralization was also an issue. Then funding, I put this in red in the sense that oftentimes we talk about funding of harm reduction, which is key and critical, but I can also assure you that there could be funding and government will still refuse to implement harm reduction program, in the sense that Nigeria has been a beneficiary of Global Fund for so many years, as has been funding interventions, HIV interventions among people who inject drugs, but needle and syringe was never implemented. How was this barrier broken? There was a catalyzation by civil society organizations, which is actually very important. We need to ensure that civil society are actually, catalyzed in the response to drug control, system and implementation of harm reduction within our countries. And part of what also, broke the barrier was international organizations, UN agencies and partners, when they decided to walk the talk. We've had a lot of documents released by the UN in support of harm reduction, the Global Fund, and all others, but when they decided to take the leadership to walk the talk with the civil society organizations who were actually on ground, then there was actually a shift. Then a multi-stakeholder engagement, which is always critical. These were very instrumental to the implementation of the NSP program in Nigeria. Now, there's no time to talk about the outcome of this, but it's always important to know that in every community where there's been resistance to harm reduction, this barrier can be broken if we can ensure that CSOs are at the forefront and international partners are actually walking the talk when it comes to harm reduction. Harm reduction is an investment in what works. So it's something we need to be able to connect, the funding and the science to ensure that lives are actually saved. Thank you very much.
Thank you very much, Adeolu. And so we move from the West African and Central African Commission to the Southern and Eastern African Commission. And so I'm pleased to give the floor to Mohamed Ahmed El Sadiq, who comes from the Global Initiative Against Transnational Organized Crime, which is basically moving this, helping building this new commission on drug policy here in South Africa. Mohamed Ahmed, yep.
Thank you very much, Professor Gadetchen. And I think it's very difficult to speak after the three speakers. They gave a very valuable information and analysis about the situation of drugs in Africa in general. Thank you very much. And I'm a little bit tall. So, is it okay now?
Maybe you can take the microphone out.
Okay, thank you. Thank you very much. Thanks, Aidan, as well as a wonderful organizer of the World Science Forum. I will just try to be very brief and talk about the East and Southern Africa Drug Commission, we'll start with a quick introduction about the Commission, the drug policy and how states are historically responded to drug trafficking and abuse has not always paid attention to the social justice, which is one of the biggest problems and barriers. Building on the network or the work of the Global Commission on Drug Policy, which we have Commissioner Professor Gadatshan here, which was advanced effectively around the world for several years, recognizing the need for more evidence-based, scientific based approaches in drugs in the region, in East and Southern Africa and globally. I'm very pleased and happy to speak and present you the East and Southern Africa Drug Commission, which is going to be launched early next year in February, headed by His Excellency President of South Africa, the former President Kgalema Motlanthe. We are going to be his secretariat as Global Commission on Global Initiative Against Transnational Organized Crime. And this commission, as His Excellency indicated, that it's an independent and high-level analysis and advocacy network, which was convened to respond to the serious and multifaceted drug problems in East and Southern Africa. And here, the Global Initiative Against Transnational Organized Crime, as I indicated earlier, is based in Geneva and will serve as secretariat for the East and Southern Africa Drug Commission. We have a network of law enforcement, we have governance and development practitioners who are dedicated to seeking a new and innovative ways in trying to tackle the drug issue, which is a little bit, it's not easy and it was not adequately responded to. Why the Commission is needed in this region? Change is the key word in this regard. Change in drug policy is really needed globally and in the region, and the regions need to lead this change. Under President Motlante's leadership, the Commission will aim at tackle these global and deep-seated issues with the focus on this region, a region where the harms of drugs and harms of drug policies are stark. I can give a bit of history about this. The Global Initiative Against Transnational Organized Crime partnered with the Global Commission, and they put in place the building blocks of regional project, which following consultations in the region and with partners has resulted in the creation of this commission under President Motlante's leadership. The commission will play a key role in the region, seeking out, supporting and disseminating the most relevant and robust research on drug markets and policies in order to inform a more effective and humane response to drug issue. The recommendations and the advocacy will put forward by the Commission will hopefully push forward to improve responses across the wider continent and through the Global Commission, as well as the broader international community, because Africa is mostly affected by the drugs and the issue, and many countries are securitizing the drug issue a lot and becomes part of their national security. It's not dealt with as in a comprehensive way. The region has become an established transit corridor for international drug flows, a long-standing maritime trafficking routes from Afghanistan and Pakistan. You can see the heroin is coming from there, passing through the East and Southern Africa route, and then ends up in the US and European markets as well. the methamphetamines regularly accompany heroin shipments along this route, which is even more serious. South Africa and Mozambique container ports are a regular recipient of South American produced cocaine. Similarly, en route to other global consumer market, which is also needs a lot of international cooperation from domestic, regional, and international cooperation. Countries in the region have significant escalation in domestic drug use, partly as a result of these drug supply chains. I mean, as I take it from what Odilu has mentioned about this is not a transit. Most of African countries are now destination countries, which is which the Commission is really needed here. If we take South Africa, Mozambique, Mauritius, Tanzania, and Kenya, for example, they are at the highest scoring African countries in ENACT Africa Organized Crime Index for the heroin trade. So drugs also can contribute heavily to the organized crime. If the levels and use of drugs in the Indian Ocean island states are also of a particular concern. Mauritius, for example, and Seychelles report among the highest rate of per capita heroin use in the world. And this is also very alarming and very serious. These issues have not been met with an adequate responses. This results in health and social harms increasing. As an example of one of the health risks that we see, heroin is mostly smoked, often mixed with other drugs, particularly tobacco and cannabis. The objectives of the East and Southern Africa Drug Commission is one, to develop a local and regional capacities and ownership, establish priority areas for action, and identify the appropriate change agents within the region and capacity support that will be needed to effect a change. 2, developing evidence-based policy recommendations based on science and expert data and analysis. Mobilizing, number 3, mobilizing public awareness and political commitment. And as Professor Gedachian mentioned also, the issue of prevention is really important in this regard. The public awareness, former heads of states of the region and other influential personalities will provide a novel analysis of the consequences of the drug control policies and their various societal impacts, all of which will be based on the latest and most innovative and sound research available in the region. The Commission will meet for the inaugural meeting, as I mentioned and indicated earlier, in February 2023 here in Cape Town, and convened by the chair will be, President Motlanthe will be present there as well, along with some other commissioners. And we look forward to come back to this city, which has this week provided us with a fresh inspiration as the Commission move into the next phase. And as we do say, science and social justice will remain at the forefront of our minds. We hope that the Commission will break the taboo and lack of effectiveness on the war on drugs, alleviate the political debate around the drug control, as well as the bridge between, act as a bridge between affected populations, civil society, and highest decision-making authorities, and between the restrictions and flexibilities of international drug control system and regional and local realities. and also provide regional stakeholders with set of a specific and tailored policy reform recommendation in this regard. I don't want to take much of the time, and I will leave anything for the questions after. Thank you very much. Thank you.
Thank you very much. So this was the last intervention. Shwayita Tobela was to sort of share the podium with you, Mohamed Ahmed, on this. That would have improved the gender balance on the panel, but unfortunately she had to leave. We have now a few minutes for discussion, and you will signal us whether there is anything coming online. One? No? It says good. Yeah, all right. And so let me ask, there's a microphone for the audience right here. Who would like to come with questions and comments? This is a totally open discussion. Yes, please. Can I ask you to introduce yourself?
Hello, everyone. My name is Al-Fadl Osman. I am from the Sudanese National Academy of Sciences. And I wanted to comment that on Monday, there was a session on the ethics of intervention on drug, tobacco, and alcohol use. And someone made the comment that the minute we moralize the conversation, science goes out the window. So there's an acknowledgement that we know that we need science to inform our decision-making and our policy-making. However, the issue around drug use is inherently a moral issue. So I wonder, how do we, and especially when you engage on the topic of drug use, and you're talking to someone who isn't a scientist, it's really hard to expect them to put aside their moral beliefs and moral views on the subject and be very objective on the subject. So I wanted to know, how do you suggest we can navigate this kind of complex nexus? Thank you.
Thank you very much. Very important point. Who'd like to answer? Monique, and then Sean.
You know, it's a very useful question, but I think a good way to engage with what is called the morality of drug use is to actually ask people what substances they put into their bodies, and to then begin to understand, you know, why it is that people judge some substances and not others. I think that it's a point that was sort of alluded to by Michelle this morning, and that was that, you know, he talked about sugar, but there are many other harmful substances that we consume despite the evidence that this is problematic. And I think if it wasn't for our consumption of these harmful substances, we wouldn't have a variety of chronic illnesses such as diabetes, hypertension, various cancers, and so on and so forth. And I think that that is the way to engage this conversation, is to say, is it more harmful to be having 3 Cokes a day than it is to be using some of the substances that would be seen as morally incorrect? That's the first way. And the other is to recognize that actually even people that moralize, to use your word, around drug use have experiences of people within their families and communities that are, you know, people who use drugs, and that actually are not able to surface or to imagine openly speaking about this. It's something that Sean and I have engaged with over a very long period of time. And Sean came up with a sort of a way of engaging people, which was called Let's Talk About Drugs and Stop the Harm. And at the Durban University of Technology, where I'm based, we had a conversation where we invited people from the public to talk about drug use in their families, in their own lives, and so on and so forth. That platform was packed out. You couldn't even stand because so many people wanted to talk openly about what was going on in their own bodies and in their families. And so I think it's really about conversations, deliberations, understanding of what we do to damage our bodies and our own health, that is about other substances that we put in it, and about not taking cognizance of what it means to be a healthy, well human being. So I do think that there are ways of dealing with that take away the morality aspect. It's very important, by the way, and I do this often in public forums, where I talk about the very, very thin line between licit and illicit drugs. And particularly when we talk about opiates, and I openly, in many forums, as standing there as a professor, will openly say that I use prescription opiates, and that then breaks down this perceived division between me and a homeless person who is using heroin, which is illicit, right? I think those are important conversations to have.
Thank you. Can you pass on the microphone to Sean? Two very important points in Monique's comments. One is the let's talk about drugs. Our slogan at the Global Commission, when we started the Commission in 2011, was break the taboo and let's have an honest and open conversation, not an ideologically loaded conversation. And I heard from Mohamed Ahmed that this is open that conversation is one of the goals of the forthcoming Southern and Eastern African Commission, and Adeolu, that was also in the sort of terms of reference of the West African Commission. And the second important point is the last one, the boundaries between licit and illicit. Just think about what happened in the US with the opioid epidemic. And think also about who decides about what is licit and what is illicit. Who decides? It's a political assembly of member states in Vienna. And they vote as member states. They receive an expert advice from WHO, but they may go against this advice if they feel so. Yeah. So again, a disconnect between the way drugs are classified, or in our language it's called scheduled. Yes, Schedule 1, 2, 3, 4. Yeah, 1 being the most dangerous, has nothing to do with the independent scientific assessment of the relative dangerosity of these drugs. And Aidan, could you show the purple report there on the chair? Yeah. And this is a report that I wrote from the Global Commission. It's 2 or 3 years old now, and it's called When Science is Left Behind, and it's about the classification and the disconnect between dangerosity as assessed by science, yeah, and dangerosity as it is in the classification, and therefore as it is in law enforcement, criminalization, punishment. And this is why, somewhere, not to quote any country here, in the Russian Federation, if you're caught with 5 grams of cannabis, this may be 15 years in prison. Yeah. Okay, so Sean, sorry.
Yes, so your question is really excellent. And I'm going to take a slightly different tack, because science doesn't move hearts in general. It's people that moves hearts. It's an emotional understanding of things. And even that involves some sort of perceived morality. So my number one thing for changing hearts and minds is to get people in front of people, which is what I spoke a little bit about today. So that's the first thing. The second thing is, when people come from a moral perspective, there are 2 levels of that. Often it is driven by a deep desire to be good, to help people in the world. And so I remember asking an imam about why he was supporting harm reduction at a harm reduction meeting we were at. And he said, because 80% of heroin is produced in Islamic countries, I have an obligation. And I thought that was a really interesting answer. Also, I found that if we can put people in front of people, the overriding thing becomes a thing of compassion. There's a danger in that as well, because you start seeing everybody as a victim or whatever it is. But when we start looking and tapping into people's compassion, we see a change. People seeing people as people. On an intellectual level, we don't even have a definition of drugs. You know, so for one person, what might be a drug might be a salvation for another person, or might not even be conceived as a drug. So in the 16th century, you got tossed into the river in a sack if you were drinking coffee in Turkey. So these things are very fluid. They are political, but ultimately, if we look at people as people, we will understand that people don't use drugs just because they want to be difficult. They use them as part of their survival, just like we do. And the most dangerous addiction of all, to money and power.
One more question. More comments?
Maybe I could ask a question, if I'm allowed.
Yes.
So we've talked a lot about addicted persons, but could you comment a little bit on the three-legged stool about how you can change with the Global Commission, say, the legal profession and the medical profession? In the sense that unless you teach the doctors about addiction, how can they actually help the patients? And we're at a conference where people are scientific, so they're told they're inquisitive when they're kids, they have a gravitas for it. But people who go into the justice profession like crime and punishment. So what do you do to actually convince the law enforcement people to be have more empathy? And then a final thing, are you looking at, say, illicit trafficking in the illicit drugs or the counterfeit side of it? Because we saw and heard that, like, I think over 60% of tobacco sales in South Africa are counterfeit. Do you protect the addicted persons from actually where they source their drugs, the quality of the drugs, and so on?
I can start.
Yes, start, and then Adeolu, I'd like you to, maybe you can.
No, you can actually start.
You start.
Yeah.
Okay. Adeolu, go ahead.
I think
Okay,
so.
okay, okay. Just permit me to also make a comment on the last question. Just a comment, and then come to this, which, I mean, because it's a very important question. One of the ways we can approach that is also getting people to understand the why of drug use. When you get people, and which also relates to let's talk about drugs. So when you get people to understand why people take drugs, it kind of bring out a reasonable dimension in the way they think. Then the other part is also getting them to understand the why for the intervention. For instance, if I'm providing an OST or an NSP, why am I intervening? And one of the things I used, because this question was, I was asked several times when we were starting the NSP program, why are you giving people clean needles? It is actually immoral for them to use drug. And then my response has always been, that is not immoral. What is more, immoral is you allowing somebody to contract HIV when you can actually prevent it with less than $1. When they look at the consequences and, it kind of shift the thinking, to the other way. Now to your question, the place of empathy is actually, very, very important. And I can see a number of things happening in some countries now around sentencing guidelines. I give an example. In Nigeria, the law stipulates that if you're caught even whatever the amount, what the law says is, as a user, a minimum of 15 years imprisonment and a maximum of 25 years imprisonment. And we have some judges who are actually giving the maximum sentence of 25 years. But most of the judges are using their discretion. Even before the sentencing guideline was developed, they were using their discretion to say, look, it doesn't make sense that I'm sending this young man to prison for just a minor offense. This shouldn't be. And sometimes they dismiss, sometimes they use the community service. So the place of empathy in this profession, is actually very important. And that is one of the ways even civil society organizations can engage with them to understand empathy the need to bring it into our responses, and that is very central.
Yeah, those are useful responses. I just wanted to say 3 quick points. The one is that neither people in the legal profession nor people in the medical profession know anything about harm reduction. Right. It's a very curious thing, right? Particularly in the medical profession. And I'm even talking here about specialists like psychiatrists. They do not want to deal with drug use disorders. I tell you, this is a true thing, right? So I think it really is our responsibility as people that are harm reduction advocates to try to find ways of including harm reduction in the academic programs of young scholars that are going into medicine and into law. What I've started to do, and it was because I was asked to do this actually by the Homeopathy Association of all, because they confronted with this issue, they don't know how to deal with it, and so now I've done a CPD course for the Homeopathic Association on harm reduction. But that can be, a similar CPD course can be done for other medical practitioners and for lawyers who require CPD courses, right? So I think there are a number of avenues there. In relation to your question about what people are buying on the market, and this is also part of harm reduction, is actually to do drug testing so that people actually know what they're putting into their bodies. And having just come back, I spent a sabbatical period recently in Canberra, the Australian Capital Territory, where they've just started drug testing. And what they've seen is that the user community is saying, I don't want to use this if I know that it's actually not what I think it is. And so, there's a wisdom there that needs to be tapped into. And as Sean was saying, if you actually involve the user community, you will be able to get good results. And so that is very useful for the police because they don't want to be collecting dead bodies. This is a very terrible thing for police to engage in. The last point that I wanted to make around science and the issue of harm reduction. When I was in Canberra, and this was in September this year, there is going to be the decriminalisation of all drugs, by the way, in the Australia Capital Territory coming into action in the next year, in 2023. When exactly that's going to happen, I'm not sure, but it will be within the next 9 months. The police were asking a very interesting question. They were saying, we know, for example, when to stop somebody for drink driving after having drunk a certain amount of alcohol. But we don't know how to deal with this in relation to, for example, cannabis, LSD, cocaine, and so on and so forth. They are not opposed to the decriminalisation. In fact, when I spoke to the police association there, they actually invited me. They said, we don't want decrim, we want legalization. That'll make our role a lot easier in all of this. But we need scientists to come on board to assist us so that we know how to regulate within this new framework, and they don't have that. And they've been excluded from the development of policy and its implementation. And I think we need, and that's why I often speak about what we see as strong actors being weak actors. The police are weak actors in this frame. They're put into a situation that they have to involve themselves in, but they've not been consulted, they don't have the evidence, they're not sure what they're doing. And I just think sometimes we need to invert our understanding of who the strong and weak actors are.
Thank you very much, Monique. And I think you're... we expect more than empathy from law enforcement. We expect participation in our debates and in our decision making. I think we're about just one more point, Aidan, to your question. Of course, drugs on the street are increasingly being adulterated. Yeah? We've seen this with fentanyl contaminating heroin in Canada, in Vancouver, in a dramatic way. Chancellor Scholz of Germany has now put in his program within the next 3 years to legalize the use of non-medical, or let's call it recreational cannabis in Germany, against the conventions, against the European law, because he says that adulteration of cannabis on the streets, that you buy on the streets, is a public health problem, and he wants to decriminalize and legalize for public health reasons. Yeah. So And the Global Commission's answer to that is drug checking is fine and is important, but the best and most intelligent and move is to move from prohibition to legal regulation of all drugs, just as we regulate alcohol and we regulate tobacco. So that's the real debate to which we all have to come to. And with this, I'd like to thank you all for a very interesting session. Please join me in thanking our speakers. And warm wishes to the new commission, Mohamed Ahmed, and dear friends from South Africa.